Okay, this is going to be Chapter 4, Body Systems and Related Conditions, page 75 of your CNA book. All right, as I just stated, it's got 10 systems we're going through, and they list them there. What I need you to know on this page is what is homeostasis. That definition is a condition in which all the body systems are working at their best. And again, anything bold, make sure you know the bolds. The bolds are telling you it's important. As well as metabolism, which are your physical and chemical processes, and what we want them working at a steady level. That is what homeostasis is. Together, those two definitions make up your homeostasis. All the systems working at their best, including the metabolism, working at a steady level. Alrighty, those are your 10 systems, and I need you to pay particular close attention to those normal change of aging. And anatomical terms of condition, and it's still on this same page. They want you to know sometimes you have to describe where something is, and you don't know how to describe it, or it's on the top of the arm. What is the top of the arm? Is it this or that? But this is how it helps to signify where you're actually talking. So, anterior or ventral means the front of the body or the body part. And as someone is anatomically correct, you will be standing like this. Right now, I can't remember, which is terrible. Anterior. Put your hands down. I like this. Right, because this is anterior. Right, okay. Anterior is the front of your body. So anything, when you're looking at it with your palms backwards, is anterior. Then your dorsal or posterior is the back of the body. Superior is toward the head. Inferior is away from the head. Medial, midline. Some of these are just as easy if you just, midline would be the middle of the arm. Sometimes you might have to describe a scar or an ulcer or a red place or a bruise. And this would help you go exactly where it needs to be, medial. Lateral is to the side, away from the midline. In other words, here's your midline, and lateral just be to the side. Proximal is closer to the torso, and distal is further away. Just know those definitions, and that'll help you when you're describing things. First system we're going to talk about is page 76, the integumentary system. Fancy word for the skin. Integument means covering. So that's what the skin does to our body. It covers it. It is a protective cover or integument. Underline that. It also prevents internal injuries to your organs. Protects us from bacteria. If it's not there, we are in trouble. Things leak out your body. If you've ever seen a burn patient, not just when they're just burnt, but a real burn, all their stuff, they swell up like they've been something, they've been soaking in something, and then all their stuff starts seeping out because we don't have the skin to keep it there. Within the layers are sweat glands, which secrete sweat, sebaceous glands, which secrete oil. We're not going to label anything, just know what they do. Sweat glands produce sweat. Sebaceous is the oil. In there also we have tiny nerve endings in our skin. The skin is also a sense organ, underline that. So it also belongs, and everything works together, but it also belongs in the sense system or in the nervous system because we're going to sense the touch. We're going to sense pain, sense all that through the skin. So it also is a sense organ, so it belongs hip in hand with the nervous system. Blood vessels dilate, underline that. Dilate actually means to get bigger when the outside temperatures are too high. You'll see it in our fair-skinned people when their face gets red. That's why it's getting red. Your blood is actually saying, I'm too hot inside, so I need to come outside and cool. And that's what, when you get a fever and you turn red, same thing. Your blood's really hope you got some air conditioning outside because now you've got a temperature of 100 inside. So hopefully it's not 100, wherever you're at, because that's why it goes to the surface of the skin actually trying to cool off. So that's why it would dilate. And constrict, and you know this, at wintertime, you're getting a lot of dry skin. Same reason. Your blood says, okay, it's cold out there, and they don't want to be out there, so it comes back into your body a little more. So your skin gets dry. That's why, and your blood vessels constrict. Just know the difference, and those are your, what I always remember so I could remember what was going on with both of them. So they constrict when it's too cold outside, and it dilates when it's too hot outside. Okay? Normal change of aging, and these you're going to have to know. I'll tell you to underline or star certain ones, but know them all. Skin is less elastic. Star that one. It's a good old big star. And it is not more elastic. People think that it is more because you're getting, you're drooping or whatever. That is not elasticity. That's the opposite. Elasticity means it stays in places where it needs to be and it bounces back. So it is less elastic. And that next one, that's a star. Protective fatty tissue is lost, so a person may feel colder. So underline that one. We all have a layer of fat that actually keeps us warm. As you age, it goes away. I don't know what that is. Hair thins and may turn gray. Wrinkles and brown spots, liver spots appear. Nails are harder and more brittle. Dry, itchy skin, maybe the lack of oil. You produce less oil the older you get. That also helps why your skin isn't as good as you age. Older adults perspire less and do not need a bath as often. And you want a bath every day. Older people, not only they're probably, especially in the nursing home, they're probably not getting dirty. But they bathe every other day. Sometimes 3 times a week. It really depends on their protocol, but most of the time it's every other day. And they keep track of that. Because some of them will refuse, and you say, okay, but you try to get them the next day. But you don't let them refuse too long. The doctor might order for you to go bathe them anyway. But a lot of times they'll give in. You just aggravate them until you go bathe them. And that would be me. I'm like, okay, they're gonna fire me if you don't let me bathe you today because you didn't bathe yesterday or the day before we got to get you today. And they'll feel more sorry for you. They don't want to get you fired. So okay, come on then. So that's a little guilt trip, but it works. Underline that last sentence as well. The NA should not cut residents' toenails. Underline that. You're not to cut toenails. You're not a podiatrist. Neither am I as an RN. An RN that does toes does that. That's because people with diabetics, bad circulation, that's most of your older population. You mess their toes up or get an infection down there, it may not come back and could die. Diabetic patients. Leave that to the professionals. Let them do it. And I always say, oh no, I'm not doing. Not that I don't mind doing toes. I'll do your toes, but don't do it because you may, how even you doing your own toes. You pull a nail on the side, and it's like a hangnail or something. Then imagine they are diabetic and elderly with bad circulation, and a diabetic especially, you got a lot of sugar there. Not only are you feeding bacteria, but the sugar's in the way of the antibiotics, so the antibiotics can't get to where it needs to go. Then on top of that, they got bad circulation. So that's why we worry about our diabetics and their feet. Always look at your patient's feet. That'll any sores or black spots especially, we need to be aware of. That's probably something happening. Something's died. Skin has died. So we watch out for that. Also, during care, you might need to report these signs: pale, white, red, and purple areas. Underline that. Any kind of pale, white, red, purple areas. That can be all kinds of stuff, but those need to be reported. When you're doing a body check, and a lot of times as you're bathing them, as you're turning them, you want to look at your patient every time you can, and report anything that's going on with them. So it may be a nurse can fix something. Maybe it's just that we need to turn them more often. Some people, some facilities turn them every hour and a half, but right now, 2 hours is where everybody saw it. But some facilities turn every hour and a half, so you just got a lot of people turning people. But just know that you might go in a facility that's one. We teach every 2 hours. But if your facility does it every 1 hour and a half, then that means they're trying to really prevent pressure sores, and they want you to go look at your patient every hour and a half at least. And that's another reason why I turn them every hour and a half. Blisters, bruises, any complaints of tingling, warmth, of burning, dry flaking skin, rashes, swelling, cuts, boils, sores, wounds, abrasions, all this needs reporting. Fluid or blood draining from the skin, and you'll see this stuff. Broken skin, changes in moistness, dryness, changes in your wound or ulcer, size, depth, drainage, color, or odor. You may smell something that you ain't smelled before. It might be that that's caused some bacteria and it's not doing a good thing. If you ever smell gangrene, I always say it, you'll know it when you smell it again. Mm-hmm. So that is an odor that has a particular kind of smell. And you'll know about when you walk in that person's room because it's in there. Redness of broken skin, scalp or hair changes, skin that appears different from normal or has changed. And they say look for an orange peel in darker skin people. And that's what they're saying is that at that area, I mean, some people are really dark. And you can't see color changes as well. And that's just because they got a lot of color. So you have to look at the texture of their skin instead of just their color. You can see like when people get on dialysis, their skin becomes dull. You know, it's a different kind of color. Even though they might have been dark skinned before, it's different. If they have a sore, it may be healing, or bruises, you can see because of a texture, not so much the color. We'll look at somebody lighter. And you can see, but you cannot see on the darker skin. So watch that as well. Be careful of your folks. Make sure they're getting watched over. Musculoskeletal system, that is your muscles and your bones. So you got muscles, bones, ligaments, tendons, cartilage. All give the body shape and structure. Underline that first sentence. Body shape and structure. How many bones we got? 206. Where two bones meet, we call that a joint. Underline that. And muscles to bone is called tendons. You don't have the bone to bone, but bone to bone is your ligaments. And that last sentence as well. Muscles provide movement of body parts to maintain posture and to produce heat. Know that exercise is important. Inactivity, immobility can result in a loss of self-esteem, depression, pneumonia, and urinary tract infections. We've already talked about that just a little bit. And activity, you have to move them, or else those things can happen. So that's important. Underline that again. Know those definitions that go along with it. Atrophy means muscles waste away or decrease in size. They become weak. Contracture is that when they get stuck. Something happens, the tendon becomes shorter and they freeze. So underline that. That's a contracture. As opposed to atrophy is just getting weak. Same thing you would do if you laid in the bed for 2 weeks. Your muscles wouldn't be as good if they maybe had a little atrophy going on. Contracture is you're stuck. What we do to help prevent that is called ROM exercises, or range of motion. Do range of motion, because again, if you don't use what you got, you will lose it. So if you don't use your range, you will lose it. I always say about my splits, you don't continue to do a split, the older you get, you won't be able to do a split. So that's the same thing. Even if it's just put your arm out, the older you get or the problems you've had, maybe you can't put your arm out. If you always hold it in one place, it's going to get stuck there. I had a knee surgery. My knee got stuck within 6 weeks. It healed stuck. And it was healed, but I was stuck. And I had to go through physical therapy after that to unstick my leg. So it happens, and it happens quickly. My ex-husband, he got a foot drop. He was always laying in the bed with his foot down. He had some severe problems. Rheumatoid arthritis, had a stroke, seizures, things like that. But in the beginning, this is when he first had his first stroke. I don't even think he had a stroke by then, but he was stuck in that, they call it foot drop. And that's why you always keep their foot at a 90-degree angle, or else they get stuck like this. And then they're going to have to work it back up. And so when he started back to walking, after he got out of the hospital, he really couldn't walk because he was stuck like this from the foot drop. He was stuck. So he had to go to physical therapy, same thing, to get that foot back working right. So that is real, and it happens. He was 25, so it happens. So don't say you're in a hospital with stroke patients. You need to really pay attention to their feet. Even I don't care what age they are. If they're not moving them, we need to get them right. Put them in place. Normal change of aging. Muscles weaken and lose tone. Now underline these. These are, you need to know the normal signs. They weaken and lose tone. Body movement slows. Bones lose density. They're more susceptible to breaks. Joints may stiffen and become painful, and height is gradually lost. Put a star by that one. As you get older, you're going to lose a little of your height. I think it's just that your spinal cord gets tired, and you done walked around and rubbed it till it just, you lose height, and that is going to happen. Get a little shorter. So if you're short, you're going to get even shorter. But if you're tall, maybe you get average. But you get a little shorter. How the NA can help. Underline, the NA can help to prevent falls by answering call lights immediately. Some of these things sound redundant, but they're going to keep telling you because this is what we need to do. Give them the call light. Do range of motions only on people who have been scheduled to do range of motions. Don't just start doing range of motion on people. Because sometimes if they are stuck, they may want you to do a little bit just to get them. Sometimes there's a brace that you might have to stretch them a little bit to put in their brace so they won't go like this. Otherwise, don't be trying to stretch them straight, or else you mess up some body parts. Again, it's just like somebody making you do a split when you just can't do it. That's what it feels like when somebody's actually trying to move those body parts when they get stuck. Observe and report changes in ability to perform their routine movements, any changes in residents' ability to perform range of motion, pain during movement, and that's one of your skills. You're going to, before you touch that patient, you're going to say, hello, my name is Cheryl Davis. I'm your CNA today. We're going to do range of motion on your shoulder. Your first sentence out your mouth after that should be, let me know if anything hurts. Because you want them to report if something hurts them. And if it hurts them, you stop what you're doing and report that. And that is your range of motion. And that is your skill. All your skills, and you should be practicing your speech. Hello, my name is, I'm your CNA today, and I will be doing whatever exercise it is. You have to look at your patient and make sure they understand what you're saying. While you're doing that, you need to provide privacy. All of that is your first 1, 2, 3 steps in every one of your skills. It never fails. You're going to introduce yourself, tell them who you are, and tell them what you're about to do. And provide privacy. So that is possibly 2 to 3 steps on every one of your skills. So get that done, and you'll be fine. What do you think the last skill is, or last couple of steps in your skill? That's nice. It's not, you don't have to ask that on the state test. But that should be asked. I would like somebody to ask that. Give them the call light, wash your hands. Or vice versa. If you had gloves on, you got to wash your hands first, then give them the call light. But call light, wash your hands. Call light. That's the secret on that one. Arthritis. Again, arthritis means anything, inflammation, swelling of. Artho is your joints, so swelling of your joints. Underline that. Or inflammation, the other word for swelling. Know that arthritis can also be caused by autoimmune disease, where your immune system is actually working against itself. It's erroneously saying we don't need this in their body, and they try to break it down. And that is not good when you need things. So that can also be caused by arthritis. That is the sure sign of rheumatoid arthritis, especially in the joints, and that's what's happening. Something in their body says, okay, something's going on in their joints, and they go in there and try to remove stuff. And this is your body's cells saying something's wrong, we need to go remove it. And that's what is your results on. And a lot of times you can see it the older you get, when you have knots, you get bigger joints. Next thing, it might be that it's a sign of early sign of rheumatoid arthritis, that you have big finger joints, and it's just something's happening there that is not normal. Some people are just born with bigger finger joints, but when they start to expand, then you'll know it's a possibility, and that's what'll happen. Your hands will slowly cramp up. So watch out for that. Arthritis. Osteoarthritis is also called degenerative joint disease, or DJD, or degenerative arthritis. Something's happening, degeneration of your bones. Osteo means bones. Joints, arthritis. So know that first definition. Also know arthritis is often treated with anti-inflammatory medications. Just underline that. A lot of times, anything swelling on your body, even, I don't care your age, if it's something swelling, take some ibuprofen or Advil or whatever that is going to reduce swelling, and your pain will go away. A lot of people take pain medicine like, say, codeine, Vicodin. Vicodin might have a little anti-swelling medication in it, but the actual pain medicine, like Dilaudid, morphine, and all of it just takes away the pain. It does not fix nothing. You don't fix a thing. That's why ibuprofen is your best choice when you know teeth swelling, you're cramping. That is something swelling causing you to cramp, and it hurts. And ibuprofen is number one on that. Anything you can get to unswell, because anything swelling inside your body that shouldn't be swelling hurts. That's why ibuprofen, that's my number one go-to medication. I don't care about all the other hard stuff. They're not fixing nothing. I always tell my story about going to the ER, and I wouldn't leave because I told them they ain't fixed nothing. Y'all ain't fixed a thing. But and that's the way that medication is. That's my pet peeve about pain medications. If you take pain medications and you have back problems, don't you think God or whoever or your neuro system tells you you're in pain for a reason? Because you're doing something wrong to your back. Imagine if you take all that pain away. You're not going to be knowing what you're doing wrong to yourself, and you're just going to mess up your back even more. And that's kind of what happens. You get so dull to the pain. If the pain medicine is that good stuff that people love to get first, which they don't need. Well, some people do. I'm not taking it for everybody. A majority, you want to feel a little pain, so you won't mess up yourself. That's why you're in pain. I always say I take that back for my headaches, because we can't fix that headache. But I need some pain medication. I can't fix it. But watch out for your pain medication. Don't take too much, because you want to feel that you're doing something wrong to your body. That's the reason it's telling you you're in pain. Something's happening. Something's wrong. Take you some ibuprofen and let it unswell. My pet peeve. Always look for stomach irritation, underline that, or heartburn from ibuprofen and stuff like that. You have to eat something. When them medicine bottles say take with medication, it's real. I have seen a lady actually throw up blood, and all they didn't do nothing. They said, oh shit, it'll fix on its own. You know what they did? DC ibuprofen. That was it. That was it. All they did was DC ibuprofen because it had irritated her stomach so much, it caused a hole, and then she threw up blood. And they went in there and checked, make sure that's what the case was, but they really didn't give her much. I always encourage activities, adapt to their daily living. You're going to be there to help them and help them adapt to what they can't do. And that's part of our job as well. Treat them as an individual and help their self-esteem. If anything, encourage them. Don't be that negative person. They don't need it. They got enough negative going on. They need somebody positive. I don't care if you had a bad day. Don't bring it to work. If you got to express it, go to the employee room and do that. Not with your patients. Osteoporosis, know that definition? It causes bones to become porous and brittle. Osteo means bones. Porous, I always think of pores. Pores are holes. So those are holes in your bones. Osteoporosis. And again, the main cause, especially in ladies, is menopause. Menopause is just when the menstruation ends. All those hormones we actually need that stop at that time, we need. But they actually give calcium salts, phosphorus. That is actually what is missing, and it helps a lot of people. So make sure you watch out for that. Hip fractures, knee replacement. All the fracture is a broken bone. That's what that word fracture is. A lot of people thinks it means different things, but fracture means broken. What's the best way to heal? Not heal, but what's the best way to prevent falls? Answer that call like ASAP, as soon as you can, or else they're going to try to get up, or they're going to try to do something, and they think they can do it. Even sometimes family members think they can do stuff and help somebody. I just read an article somewhere about this lady thought her father, they shouldn't use a Hoyer lift on him, but he weighed 300 pounds, that they should be able to just transfer him wherever he needs to go without using the Hoyer lift. I don't know why, but she had a moral dilemma, like, do I let the lady, who's the daughter, try to pick him up, or what do I do? Because she didn't want him to use the Hoyer lift, so she ended up calling 3 or 4 people in to help pick him up, which is not cool. And my suggestion to her was they need better, more care. If they want that care, and 3 or 4 people, then they need to order that and charge for that. That's because you're taking away from all those other people that needs a nurse or a CNA. So, I don't. But I don't have a clue. But I say, yeah, he can have that one-on-one care. But he's still gonna need a Hoyer lift even if you pay a whole person to sit with him 24/7, because they wanted him checked every 15 minutes. It's not possible, not with other patients. Just to make sure you check him every 15 minutes. That's fine, but you're gonna have to pay for that. That's some extra care. If you're gonna be in that, you're gonna need a whole nother unit or a person that you pay sitting with them. And that was the suggestion. Just make sure, watch out for those people, and answer those call outs. The surgery is often, a lot of people will just be walking, and because their bones are so brittle, they fall and break something. They actually have probably broke before they fell, or they fall and break something. Sometimes you can tell the difference by people's bones, I've seen someone turn a patient and break their hip. Nobody got in trouble because it wasn't nothing being done wrong. There was actually 3 people turning this patient. So when that they were doing anything wrong, it's just the process of it. And they were so glad that they had a witness. One of them was a nurse and 2 CNAs. Good. But they were all of them was in there and broke her hip, not from force or anything, just from her movement. And nobody got in trouble because they was doing what they were supposed to do. But it was bad for the bones. You gotta watch people. So you don't be pushing on them too hard. Always use the drop sheet when you can. We call it a drop sheet, depends on where you're at. Make sure you do that. Hip replacement guidelines. Keep often used items in easy reach. Just put easy reach. Anything they need needs to be in easy reach, or else they're going to try to reach for something and fall. Underline, this is probably your most important thing. You're going to see this every time it goes, especially with your stroke patients. Dress the affected weaker side first. How many, and I always think, when I think weaker or affected, I think of a big old cast on my arm. Okay, if I got a big old cast on my arm, and y'all done dress some of your children or sisters, whoever, but if you imagine you got a whole cast on your arm, if you put your clothes on this side, how are you going to stretch that whole shirt out to put your arm in there? That's not ever going to happen because you're stuck. How are you going to do it? It's not possible. So you always dress the weaker side first. Dress this, and then you can work your arm in. Work your arm through the sleeves and everything, but dress the weaker side first. or else you're gonna be in trouble, and y'all just be sitting there, and you'll figure it out, cause they're gonna have one side of their body dressed, and you can't stretch the whole shirt to put it over there. I always think when you think weaker side in your head, think that, so that'll help you. Also know your definitions of partial weight bearing. That's exactly what it means, that you're partially weight bearing. You can support some weight on one or both. Non-weight means non-weight. Don't put nothing on it. When I had my knee surgery, it was no weight on my right leg. None. They didn't even want me to put my toe on the floor for balance. It healed just fine, but I told you I was stuck. But that is non-weight bearing. Full weight bearing, it means they can walk. Does not mean that they can walk straight or without any help. It means they can put their whole body on it. And after hip surgeries, you will see that the progress that they'll allow them to start doing. Because they're not just going to go straight out and start running. Even though they've healed, they got to get rehab. Okay. And that last sentence, never perform range of motion exercises on an operated leg. You mess them up. Page 80, that first one there. Caution the resident not to sit with their legs crossed. That can actually mess up the whole surgery. You can mess them up. I've actually seen that too. The person they didn't know, but they re-broke their hip. And it was, and you can break, your hip is like this, and then it goes into a socket. You can break anywhere in there. And that's what she did. It was broken like here before, but she broke it up in here, messing with it. Bending where they're not supposed to bend. You don't want them, they can only bend. They should be at a 90-degree angle. If they bend to the floor, don't let them. Somebody else should be tying their shoes. If they drop something, somebody else needs to pick it up. They do not bend at all, because that is messing with their surgeries. And because of the way your bone sits in your hip bone, any of your movement is messing with that surgery. So we do not let them bend. We don't let them do any of that. This would be your hip socket, and this would be the leg. When they break a hip, it's either they've broken like a piece of that socket here, or they broke their leg here. If they really broke it pretty good, it's gonna be broke at that big old knot. Y'all seen the knot on the end of a leg bone? They break that whole little knot off. So we gotta really watch them. Do not let them bend. They have to stay at that 90 degree. Also, don't let them cross your legs. Underline start at 10 times. Crossing the legs will mess it up as well too. And that's why we have what we call an abduction pillow. Saying it keeps legs away. And you'll learn some more terms like that when we talk about range of motion. But abduction, just like you abduct a child, you take it away. So abduction would be taken away. Add is bringing back to. They cannot do adduction. They have to keep it abducted, and that's an abduction pillow. So make sure you know what an abduction pillow is as well. It can be used up to 6 to 12 weeks. Depends on what the doctor says. So we really got to watch our patients, and that they're not doing things that'll mess up their healing process. Underline that. Right up under the picture as well. When transferring from bed to bed, use a pillow between the thighs. When you're taking them from bed to bed, still do not let the knees touch. You put a pillow between them. A lot of people will fold with a pillow. Or sometimes there's actually a wedge, kind of like that wedge, but it's just for their knees. But you don't let them touch, because that's, again, messing with the surgery. Raise the head of the bed. This allows the resident to move her legs over the side of the bed. Your best bet, and to save your back, when you're picking up a patient, you don't have to pick them up from a laying position. They should be in a hospital bed or something of that sort, that you can lift the head of the bed, and it actually gets them almost sitting up, and then you can help them. For your hip fracture people, you really you have to move them together as one. You do not just put this leg over and then do that leg. You grab them together. And that's your how you do the legs. Stand on one side of the unaffected hip. The strong side should lead in standing, pivoting, and sitting. What that means is, say you're going to transfer a patient from one bed to another, or to a wheelchair, whatever, but you're gonna have to transfer them. You want their strong leg to lead, their strong leg, so, cause this is what can happen, and you do this. You walk on your strong leg, then you drag your bad leg. Say you hurt your ankle. You're gonna walk on that strong leg, and then you're gonna drag the bad one. Because you can only touch that little ankle a little bit. Until your ankles heal, people, they have a little limp. Same here. But to get them to help you, they can, when you move, you can use that one leg, and that's your strong leg. So you want them to use that strong leg. So where would you park their wheelchair when you're trying to take them somewhere? On the strong leg, or strong side or weak side? Strong side. Because they're going to be able to help get to the edge of the bed. Then they're going to be able to put their strong leg down and drag the other leg. And that's fine. That's how a lot of your stroke patients will do. You'll get to know that very fast. Which one is their strong side? Because that's the side they're going to help you on. If you park that wheelchair on their weak side if you want to. And they're leading with their weak leg. Both of y'all are in trouble. Because y'all going to be probably on the floor somewhere. Because there's no help when it's like that. So park it on the strong side. Then you could always be wonderful. Report any of these to the nurse. Redness, draining, bleeding, warp, or anything incision to the area. Any heat. Anything, any foul odor, any getting bigger, size and getting bigger. Especially heat and redness. Something got infected probably. Any increases in pain, shortening or external rotation. Your legs are normally like this. Your external rotation means that the leg possibly being re-broke, because that's the first sign of hip bone being broken. They could have been laying in the bed and they break, and their leg would be just this, like this. Your foot and everything would be just kind of like this and a little bit shorter, because it's broken in that hip joint, and that's what it does. But their legs will be like that internal. So always watch out for that. That's a sure sign of hip broke. Even, they could be just laying in the bed and broke a hip. So, but they try to warn you of those people, because they've probably done some studies on them already. Know they got brittle bones or easily broken bones, and they'll let you know. But that's your first sign. Look at your patient, and then you. Total knee replacement is a surgical replacement of the knee with a prosthetic knee. They actually take whatever you got, your whole knee, and give you another one. And actually, that's a wonderful thing. I didn't have a total knee, but they told me later on in life I probably would. I done had 2 knee surgeries, but they didn't see fit for me to have a total knee. Because another reason total knees go bad in 15 years or something, and I was 20 something. Okay. So no matter what, they was telling me my knee's gonna go bad when I turn 40.
They told me I'd have to have one by 20. I'll be 40 next month and have to have one.
Yep. And they'll tell you that. Have you had knee surgery before too?
Had 3.
Yep.
First one, I took a piece of my hip and broke it.
Ah. And see, they give you bad news, like by the time you're this age. But I know it'll be fine. I'll get a brand new knee. But I don't want them going in there cutting on me again. But if it need be, give me a new knee, I'll take it. I'll be buying it woman knee. But I don't want it to happen. But everybody, I got a friend who just refuses to go get her knee done. And she knows she needs it done. She all limping and won't move right and can't move right. But all she needs to do is get her knee fixed.
And that's it, once they finally do it, it's the best thing they ever do.
Yes. It's terrible. Get your knee fixed, man, and then we can go places. Because this is my real good friend.
Oh.
I remember Max when he got his done, and it was a lady that I worked with. I heard that she had 2 knee replacement at one time.
Ooh.
And she'd say, look, I can put both of my legs behind my head. And they heard her say it in the back. She said, that's a dirty old woman. I said, no, she just over happy.
Yeah, this gonna make you happy.
Because she didn't have any pain anymore.
Yeah. That's all right. That's where you want. And a lot of people just don't realize, you sit here and my friend, and you know my friend, that one in the picture with me. But Her knees hurt her all the time. I'm like, go get your knees fixed. They told me I need them fixed, but you know, they're working, or she'll take medicine 24/7. Go get your knees fixed. She's been working all her life, won't stop working. She works 2 jobs. Stop working. Got sick not too long ago, but that's the only time she stays out, and then she goes back to working. No, I don't know if she's still at work now, but I mean, she might have already went back to work, but she's got, she needs her knees fixed. I wish she'd fix them, and then she wouldn't have all that pain. I promise you, mine was stuck and hurting, and I wasn't leaving until they fixed me. I could have walked around like that, but I felt my bones. I felt them. Bones, I felt them. I can't walk around. If I walk like this with my leg crooked, just slightly crooked and to the right a little bit, then I could walk right. I mean, I wouldn't feel pain. Because I guess the little cartilage that was there was cushioning from bone to bone. Otherwise, it was bone to bone. Yeah. I wish you would get them fixed. To prevent blood clots, apply special stocking as ordered. One type is a compression stocking. It's a plastic air-filled sleeve-like device. Has anybody you would have had a recent baby? How old is your baby?
13
That's been a long
4-year-old. Maybe did they put that big long sleeve? It looks like it's just like a white giant blood pressure cuff. That's what it looks like. But it covers your whole leg all the way down.
Yeah.
Most lower surgeries now, if you have a C-section, right after surgeries of your lower part, they'll put that compression on, because it makes your muscles think that you got circulation going on, and it's to prevent blood clots, and that's what they're talking about right there when they're saying that type of compression. There also is some compression stockings that we can use to help circulation as well, and help some blood vessels tighten up a little bit, so circulation will be better. But at what they're talking about is actually a little machine that blows air into it. It's like an inner tube around your leg. Blows air in it and lets it out. Blows air in it and lets it out. And that helps your body think that it's got some blood circulation. Huh?
The ones that have water going through?
Yep, same thing. It's all simulating some kind of movement. Circulation helps that circulation. It keeps away from blood clots. That's the main part. Especially anything lower surgeries. They're worried about that blood clot. They'll be in the back of the leg. And that's where that first one would be most of the time. They call it a DVT. But that's what we're trying to look and make sure we don't get. And always encourage fluids, especially cranberry and orange juice, vitamin C. All of that helps prevent urinary tract infections, and older people get it like it's just something to pick up, and literally. So make sure you're drinking vitamin C, orange juice, or cranberry juice. Even yourself. When you find, and I actually, when I'm using the bathroom and I just feel like a little tinge or something that felt like it might be burning, let me give me some cranberry juice, orange juice, something to help flush. As long as you flush that out. Because I've noticed that before. Just drink you something. Preferably cranberry juice. It changes acidity, and things like that. But anytime, especially when you're urinating and you feel just a little burn, get it then, because that's bacteria messing with you. So make sure you get it and try to flush it out, or else you will have a UTI. Next thing you know, you're really gonna be hurt. And it won't be just a little sign. Okay. Assist with deep breathing exercises as well. People that have surgeries, they actually give you some medication that kind of paralyzes you, but they help you still breathe afterwards, which is just as crazy. That's why you sign that piece of paper. But that says, I may not survive, but that's that consent. But we give deep breathing exercises because you've done that. We need to get them to get some oxygen flowing through their body. Ask the nurse to get pain medications. Anybody that's had a surgery, don't withhold their pain medications. Just bring it to them. Don't make me ask for it. Just give it to me, because anytime you let pain sit on you, and that's just what happens. You got pain receptors, and it's harder to relieve those pain receptors once it sits on you. Same as it's harder to relieve swelling once it sits on you. Same thing. Give me some pain medicine. I even know every once a month I have to take ibuprofen 100, and I feel that pain. I'm like, ooh, there you go. And it switches from side to side each month. I know that's it. That's it. And I feel that little cramping because mine gets real bad. Like somebody's tearing out my insides. But if I just take that one ibuprofen, that one day, I'm done with it. After that, it might ache me a little, but that one day, that pain I don't feel. That's one day a month I'm taking. After that, and 400 might even help. Not ibuprofen 800, 400. As long as you get it before it sits on you, or else you're gonna be in trouble. So help with the pain medications. If we as CNAs, we can reposition the patient. We can put a pillow over here. You know, sitting in one place too long is gonna hurt you anyway. You should be turning them anyway. But what you're gonna see, say you're working in a hospital, you're gonna see grown people that can walk normally, that hadn't moved in 8 hours. They just been sitting up in there in the hospital bed, and you see it all the time. They haven't moved. They just sitting there, half of them like this. You're like, get yourself up, sit up. But that's what you do. You go ahead and sit your patient up, make sure they're sitting right in the bed, and try to turn them, try to get them and tell them. Because if they're not moving, again, I don't care how healthy you are, you're not moving your nothing. Your lungs, that's how people get pneumonia in the hospital. And we'll reiterate it every time, but especially when we talk about non-movement. Just make sure that make sure you move your patient. Report to the nurse if you notice redness, swelling, heat, or deep tenderness in one or both calves. That is that back there that they're trying to prevent, called DVT, deep vein thrombosis. Thrombosis means clot. Deep vein clot is what that they're asking about. Right there. So let's move to the nervous system. The nervous system is a control and message center of the body. Underline that, and it coordinates all bodily functions. All that, them first two sentences. So you got your nervous system. You got your central nervous system. Don't confuse it. Don't think too hard. It's what's in the center of your body. What's in the center of your body? Your brain and your spinal cord. Everything else is called the periphery because it's on the periphery, just like your peripheral vision. They do that. Y'all should know peripheral vision. They test it at when you go get your driver's license. Tell you to look on here and see if the light's flashing. That's your peripheral vision. Your center is here. Brain, spinal cord, everything in there. And then everything else is your periphery. And that's how you label that body part. Normal change of aging. Underline these. Responses and reflexes slow. Sensitivity of nerve endings in your skin decrease. That's another thing while we were talking about, say the older person touches a stove, they don't move as fast, so they're going to have more damage. And it's because they don't jump as fast as we do. We're going to jump all that ASAP. And maybe feel a little heat, maybe not be burned at all. But they probably going to get burned because they're going to move slower. That one little extra half a second causes damage. So make sure, know that their sensitivity of nerve endings decrease, and they may show some memory loss. That's normal. I'm seeing that now. I really hope that it doesn't get any worse.
My balance is.
To help people with memory problems, give them the right notes, give them the right things down. I'm terrible. If I don't think it's important, I'm probably not going to remember it. So, from day to day, you don't know what's important. So I'm not writing a diary and journal and everything. So I tend to forget a lot of stuff. You're gonna probably have to remind me. But how we can help is calendars, to-do notes, all that kind of stuff. Actually, will help them. Reading, thinking, and other mental activities should be encouraged. That last sentence in that orange box. Reading, thinking, and other mental activities. Keep your brain busy, same as your arms and legs. If you don't use it, you're gonna lose it. So make it work. What we're gonna observe and report for your central nervous system, any fatigue or any pain with movement or exercise, shaking or trembling, inability to move one side of the body, what might that be? We're talking about nervous system, one side of the body. Could be a Stroke. Anything one side of your body is a stroke. Difficulty speaking or slurring, stroke. Numbness, tingling, stroke. Disturbance or changes in vision or hearing, all that could be signs of a stroke. Or just things kept going bad. But all that's got to do with your brain and your spinal cord. Anything that messes up your brain can mess up a whole lot of stuff. That's these here. Dizziness, loss of balance, changes in eating patterns, fluid intake, difficulty swallowing. A lot of this is caused by, that CBA. Memory loss, confusion, violent behavior. Something's going on wrong with the brain. Any unusual or unexplained change in behaviors or decreased ability to perform their ADLs. And now that is our very next thing we're talking about, page 82, which is stroke, which is your cerebral vascular accident that y'all had on y'all's test already. So y'all know that. Underline, it occurs when a body supply to part of the brain is blocked or the blood vessel leaks or ruptures within the brain. So same thing, plumbing. Something happened, it's either you got a leak or something burst in the wrong place. It's called the brain. And any kind of problems like that will affect wherever it's leaking at or wherever it bursted at. That we got to fix ASAP. Sometimes that part is blocked and it doesn't feed the rest of your brain. Those brain cells die. And that is why we try our best to treat strokes ASAP, as soon as possible. If you think somebody's having a stroke, you get them to the ER. Because they can get some medications. Or have some bear hanging around. Anything that may thin the blood a little bit. So it won't, so if it's a clot, it'll start breaking it down. Or try to help the blood flow. So, but they show a little picture of that. Ischemic stroke means something happened. They're not getting blood supply to that part of the brain, so it dies. Okay. Sometimes that will cause what we call hemiplegia. Hema, just like your hemisphere of your earth is half of the earth, the hemisphere, you got the north and south hemisphere. That is the same thing, paralysis on one side of the body. So know what hemiplegia is, one side of the body. And hemiparesis, just same thing, but it's weakness on one side of the body, hema. Know what expressive aphasia is. Something's affected the brain. And expressive means I am talking, but I can understand what you're saying, but I can't tell you what I'm saying. If that means anything. I can express myself. I can understand what you're saying. You're telling me, I need to get up, or what's my name? I know my name, but I cannot tell you my name. That is expressive aphasia. Know the difference in those two.
What
And
side of the brain?
either.
One?
It can be either. But I think it's more, because that's going to be like middle of the brain. I don't know. But it is one that's going to really mess with it. Whereas the other one just kind of,
I got a picture.
It's
of it.
possibility.
It's just that
what,
she'll sit there and try to say it and it just,
what else is affected on her?
her speech.
Speech. And that's it? No weakness in one arm opposed to the other? Well, they sure got that.
Her walking maybe. She walks like,
A little
she takes
unbalanced.
steps,
You
She
might
takes
can
little
figure out,
steps
it
like
may
shovels.
be,
yeah.
it may be that, you might can pinpoint one side. You might could, get her to hold her hands and get them to pull real hard and see if they're pulling harder on one side or the other. Something like that.
I tried it.
Yeah, you might can figure out exactly which side actually messes with the speech language. Receptive aphasia. That's saying I can say and I can talk and I'm saying everything. That's probably how y'all feel sometimes. I'm saying stuff and y'all don't understand it. That's what receptive aphasia is. It's saying that I can talk, but I don't understand. I can't receive what you're telling me. In other words, I can talk all day. You ask me my name, and I'm not getting it. Am I saying that right? I can't. I don't understand what you're saying.
Not comprehending.
I don't know a word what you're saying, but I know my name, but I can't say it. I mean, expressive aphasia, I can't say it. receptive is I just can't understand what you're saying. It's like everything sounds alien. You're talking a whole nother language. That's receptive. I can't receive what you're giving me. Okay, we'll leave it with that. Loss of bowel or bladder control. That's a lot of times they have a stroke. That's where that incontinence come from. Sometimes it could be other causes too. Confusion, poor judgment, memory loss. Tendency to ignore one side of the body, they call it one-sided neglect. Also, emotional lability. In other words, they're weirdly strange. I had a friend that had a stroke. She was a nurse. She came back to work. I would have known anything was wrong with her until she just would bust out laughing at nothing. Or she would cry and she was like, ever since I had that stroke, I've been doing this. And it was... That's a sure sign, and they tell you that. That's why they say after a stroke, a lot of people just don't go back to work. But imagine you know, at a funeral and burst out laughing. You know, there's something like that. You know, and that's, that's kind of what they do at weird times. And they just start laughing or start crying. That'd be appropriate, but probably they'd be laughing at the wrong time. Difficulty swallowing, underline that, that's a major word in your vocabulary. You need to know what dysphagia means. Dysphagia is difficulty swallowing. And again, it's both, either the right or the left side of the body. Most of the time, sometimes they're all from head to toe down. They may have what they call paraplegia, and we'll learn that in a minute. But when you think it's stroke, it's usually one side of the brain, so one side is weaker. One side is affected. That's what you want to think. If it's a certain part of the brain, like hers, I would like to figure out where it really is. Also, never refer to the weaker side as the bad side. We're going to say weaker or involved. I don't say none of that. I say, let me get the right leg. If I have to tell you, let me get that right leg, that's what I'll say. Right or left or something like that. I don't say you messed up leg, your bad leg, your broke leg. Of course, we know a broke leg. But, you know, you don't want to refer to it like that. Also know, and this is a reiteration, that your speech therapists are also going to see how good they swallow. They evaluate a resident's swallowing ability. Underline that one more time. And you see that's important. During a stroke, a lot of times it affects their throat. They can't swallow. And that's why a lot of your nursing home patients are eating pureed foods or thickened fluids, because they can't swallow right, and that's what the stroke will mess with it. So your speech therapist evaluates swallowing ability. Okay, always make sure that you are. They're talking about they often cry for no reason. Make sure you still give them time and to do for themselves. They can do it. Let them try. A lot of times nerve endings can actually come back together, so you still let them try to do what they can for themselves. And encourage. Always check on the resident's body alignment. You don't want to leave them, because they can't feel something, right? You know, they got their arm all tied up in the bed. And sometimes they get loose circulation, mess up their body parts. So you always get their arms, legs, put them where they belong, even though they can't feel them. You put them where they belong in anatomical position. You don't let them just hang, you know, all this body parts all messed up on the right side. You get them and sit them where they're supposed to be. And we're going to do that every 2 hours. We're checking on them, we're turning them, and if they're all in some weird position, make sure, because they may have their hands stuck somewhere and don't even know it. So make sure that we're watching out for them, and that, especially if they can't feel. We've already talked about make sure you get them started on their stronger side. If you're walking a patient who has had a stroke, do you walk on their stronger side or their weaker side? Weaker. You got to support the weaker side. You, when you're transferring a patient, what do you transfer with?
The stronger
side. You start with the stronger side. But when you're walking with your patient, you walk on the weaker side. Okay. All right. Remember, when assisting with dressing, dress the weaker side first. Underline that again. You're going to hear that. Which side do you dress first? That is one of your skills too. You're going to say, hello, my name is Cheryl Davis. We're going to dress you today. Which shirt would you like to wear? That's their freedom of choice. And you're going to figure out which side is weaker. and we're gonna probably know which side state is the right side. On the state test, your right side is gonna be weaker. So if your right side is weaker, which side are we gonna take your clothes off first? This is opposite.
Take them off.
What do you take them off of? Well,
You take it off the strong side first.
stronger side. Take it off your stronger side, because you can do all that, and then you can just pull it off. You can work it off the cast, or I always think of cast. You work it this way. But if we're gonna put on your clothes, what do we put on? Put it on weaker, then you can maneuver in. Okay, y'all got that. Flip on over. Try to make sure if this patient cannot talk. You know, normally we ask open-ended questions that gives you more answers. If they cannot talk, or we got to find a way to communicate. You know, one finger up, one blink, depends on how bad it is. You know, one blink means yes, two means no. One finger means yes, two means no. Whatever they can do, you find a way to communicate, especially a yes or no, at least that, and be able to communicate with your patient. And also, there's that communication board again. If they've had a stroke, maybe they can't express what they want, but they can figure it out. Here's a piece of paper, that's what I want right there. So that communication board is wonderful also. Always give your residents time to respond. Don't rush them. They may be thinking in their head. They're trying to gather up the words to say what they need to say. So give them that time. A lot of times, we're just going to have to learn how to do some nonverbal communication, gestures, and stuff like that, just to get them to where we need to get them. Okay, come on. Let's go. We're going to eat. Always. There's some gestures to go through your day. If they have speech impairment, never speak to the patients as if they're not there. They may cannot say a word, nothing, but they may can hear exactly everything you're saying. So always watch what you're saying in front of your patient. Okay. Parkinson's disease, underline, it is a progressive, incurable disease and gets worse with time. The brain degenerates. A lot of times they call it a little shuffling gait. They got a little walk to them. They walk with purpose, but small little steps. And they're also the one that they're shaking to death. They're doing this number. So if you give them something to drink, what are we going to do? Make sure it has a lid on it. Or like a toddler cup, but you want to call it that. But sippy cups and things like that. Very similar, but we're not going to call them none of that. It's going to be something with a lid on it. Because, you know, they're shaking like that. A lot of them still want to eat, but they're like this. They got just mess. They will make a mess on themselves. But if they want to feed themselves, you try to give them that leeway. Let them try to feed themselves. A lot of people don't want help, so let them try to feed themselves. Know that gait. Also, the other word for that is walk. Gait, or I should say a gait is how they walk. For Parkinson's, they call it a shuffling gait. And if you're unbalanced, we'll say your gait is unbalanced. It's a way that you walk. So when they use that word gait, it's describing how they walk. Residents are high risk for falls if they've had strokes or Parkinson's. We're going to help with ADLs and encourage self-care. Multiple sclerosis. It's a progressive disease. It affects your central nervous system. How I describe it is like a line. You got a wire. Same thing. But it's a wire. And it's sclerosed. Sclerosed means scarring. So if you are sclerosed at places, you have synapses in your body that back when, you got to go a little back and remember, like there's little, from nerve to nerve, there's a little, they call it the synapse in the middle, that things have to happen in that synapse to get to the next nerve. And if that is scarred, or this is scarred in any way, whatever's going to happen there may mess up. And multiple sclerosis people, a lot of times there's a scar right there in those areas, and it doesn't reach there. Say they want to pick up their arm, but instead it may pick up their arm, but it also may hit the pain nerve, but it hurts like hell. And that's what a lot of because the synapses synapse the wrong way. If that makes any sense. The nerve jumps, or the information is wrong that is sending from each nerve to nerve, and that's what your problems are with your multiple sclerosis people. The multiple scarring along their nervous system, and it causes problems. That's exactly what it is. A lot of times they're diagnosed in the early 20s and 30s just because that's when they start having those problems. A lot of times if you're having those problems later in life, it might be you just getting old. But most of the time, between your 20s and 30s, you will, what has son got me? You will be diagnosed with multiple sclerosis, and they give you a shot. Sometimes it's every month, but it helps. So just be aware. If somebody tells you they got MS, they're probably painful. Help with their ABS is needed. Give plenty of time to communicate. They also might get tired easy. It reminds you of, like they've had a stroke. They've had some kind of heart failure, congestive heart failure. They can't breathe sometimes. It really just depends on what's going on, where it's messed up in. Yes, I mean it can mess them up. You got all kind of nerve impulses going through your body, and when those are messed up, it can be bad. Head and spinal cord injuries. Sometimes diving, sports injuries, falls, cars, motorcycle accidents, industrial accidents, war, criminal violence are common causes of head and spinal cord injuries. I can count. I know at least 5 people that all they did was jump in a swimming pool and hit their head on the bottom of the swimming pool, and I got paraplegic. Two of them actually was, I think it might have been 3 of them at Southwestern for years. And they were in their teens, jumping in the water, and hit the bottom. Or it could be a lake. They thought it was had a long, big bottom. Something that they hit and messed up their head. But it can cause paraplegia. And I always remember that it's not, hemiplegia means half of the body. Paraplegia is when the spinal cord is messed up. And I always say paraplegia. So the legs. Pair legs, got a pair of legs. Or quadriplegia means everything, hands and legs, or arms and legs. Know the difference in those two. Paraplegia means your arms. Don't get it confused with hemo. Hemo is one side. Para is going with your spinal cord. So if your spinal cord is injured, the lower it's injured, the less damage your hand. The higher you get because of the way your body works, all this is connected to your brain. If you make up the connection right here, ain't nothing else gonna work. If you mess it up here, ain't nothing else gonna work. There's so many things. Y'all heard of the cranial nerves? They're all up in here. So you messing up something up in here, you may not live. And that's how that works. And that's why when you're having car accidents, they're putting the braces on your neck on purpose. People play with it. But if they're putting that on your neck, they're worried that you've had some kind of neck injury, and it can cause damage. And that's why. Because everything's going on up under here. You've got them nerves that connect to everything else in your body that makes everything else work. And that's your brain. Now, if you have an injury and it's further down your back, all that stuff that controls all of that is going to work. And maybe you can't urinate. And maybe your legs don't work, depending on where the damage was on that spinal cord. But up here, that's your lungs, that's your breathing, that's your everything, your vision, sight up in here. If that's messed up, it might be messed up. Your last nerve, which is 12, does all your hands and arms. So we really watch out for our pupils. And it really depends on where it's messed up at. You mess this up, you in trouble. And if you come on down a little bit, maybe not as bad. You can still, that's what a lot of your people in their wheelchairs still rolling around, playing basketball, they can still do. That is lower back. And the further up, the worse. If you get it up near here, talking in your back, it's going to start affecting your breathing. Can't breathe without machine, maybe, whatever. It really depends on where it's at. So paraplegia, paralegs, and quadriplegia means both. So remember that. When somebody says that they're quadriplegia, you're really going to have to take care of that patient. Paraplegia, maybe they can bathe themselves on the front, maybe not so good in the back. Maybe they can do their back as well. But the more, you're going to have a lot of work, quadriplegia, paraplegia, maybe they can do for you. And I always say, if the older person, I don't care if they're weak or old, if they can roll that wheelchair, and this is me in my funniness. Not really, but I do it. If they can whirl their wheelchair, they can put a napkin, a wash rag in their hand and clean their front parts.
Mhm.
And that's what I tell them. Here's your washcloth and here's your soap. I'll soap it up for them, get it all good, and go ahead. You can clean that front part. I'll get your backside. But if they can roll that wheelchair, go to lunch and eat, they're doing a lot with their arm. They can wash themselves right there. So, get participation going on when y'all are cleaning your patients. What I call participation. We're gonna get this done as quickly as possible. Here is your washcloth. I'll be working on this, and you work on that. But I will go behind them and wipe, make sure they didn't leave soap and stuff like that. But yeah, they can help you out. And that'll give them something to do, and y'all won't feel so crazy as well, especially in the beginning when y'all first start. Health and spinal cord injury guidelines, give emotional support. Safety is very important. Be patient with self-care. Give careful skin care. Underline, assist residents to change position at least every 2 hours. That's at least. Some facilities are going to an hour and a half. It's gonna be a lot of work. I hope they got enough CNAs to ask that of y'all. You know what I'm saying? I really do. Assist residents to change position at least every 2 hours. Perform your range of motion exercises as ordered. Immobility tests immobility leads to constipation. So we're gonna try to move them as much as possible. Even us sitting still can get constipated if we don't move around. So makes that as well. Lack of activity leads to poor circulation. They might have difficulty coughing or shallow breathing. They tend to catch, if it's affected way up here, we're really worried about them dying of something of lung because, all this, you've got to use your muscles down here to open and expand your lungs. If that is messed up, anyway, even if that one muscle doesn't work, you're not expanding your lungs as good, so we're worried about their lungs. Even if they are breathing on their own, we still worry because, if that muscle was affected that's right below it, maybe they're not opening up as good, which would cause pneumonia. And no movement in the lungs. No movement causes bacteria to grow. They love it. Bacteria's like, yay, I get to stay in my house. But if you drinking water and moving, then they're always constantly being flushed away. That is your ticket. Drink some water and movement. The nervous system, your sense organs, and we're going to go through all the way to 4 and then we'll take a break. The nervous system, sense organs. You got your ears, eyes, nose, tongue, and skin. They're all part of your nervous system and also sense organs. So there, we're not going to have to label anything. I'm not going to ask y'all to label it. Just know what is there. And if somebody says their pupil hurts or whatever, that may be a strange thing for somebody to say. Normally they'll just say their eye hurts. I don't know if anybody's pupils can even hurt, but they'll say their eye hurts. So just make sure that if somebody reports something to you, that you report it accurately to the next person. You won't have to explain things that's going on with people because that would be your nurse's job or the doctor's job. But if the eye hurts, that's what you chart, or that's what you tell your nurse. Ear, same as that. We do know about the tympanic membrane. That's not even labeled there, but that tympanic membrane is what we worry about with ears. We're trying to clean ears. That's why we don't clean ears. We might pour water down them and allow it to drain out. We don't go sticking. You barely should do it to your own ears because you can feel, when it hurts or when you're doing something wrong. But don't go doing that to nobody else's ears. How we clean an ear, it will allow the water to get in there and then allow it to come out. That's how you clean an ear. So don't go digging in other people's ears. Normal change of aging. Vision and hearing decrease. That's normal. Sense of balance may be affected. Sense of taste, smell, and touch decrease. Sensitivity to heat and cold decrease. So now your sensitivity is decreased. Your reflexes are slow. That's going to just add to me burning my hand on my stove. So make sure we're watching after our older people. Their reflexes aren't good. Their senses aren't not as good. It doesn't mean they're not going to move when they need to move, but just know they're a little slow. If residents have eyeglasses, make sure they have them so they can see. That is part of their quality of life. That is a patient right. If they have something that they need to, if they can't see, if they can't hear, we need to give them a hearing aid. If they can. Sometimes you just can't fix it. It may be a nerve problem you can't fix. Sometimes it's a little mechanical problem. Give them a hearing aid. They'll fix something, hopefully. But whatever they need, the part of the quality of life is to help them get there. If they can't see, they need glasses. If they can't walk steadily, maybe if they just get a cane, they can. Or a walker, maybe they can. All of those are part of their quality of life, so make sure. We're talking about senses here, so they're talking about eyeglasses and hearing aids at that point. Sometimes their smell decreases as well. They might not realize that they're smelling. So you don't have to tell them they're smelling. You just make sure you're offering baths so they won't be smelling. Notify for your eyes and ears, changes in vision or hearing, signs of infection, any dizziness. Dizziness can also, it may not be blood pressure issues, it may be ear issues. I couldn't ride in a car and get dizzy. And I would always fall out as a child. But they later diagnosed me with swimmer's ear, because I always swim. So, but fluids had built up back there. So I was really dizzy. They get in a car, and you know how a car, probably a bad car too, back in the days, probably shouldn't be to death. And I had to go to sleep, or else I would be so nauseous I want to throw up on somebody, or so dizzy. So I just go to sleep. I get in the car, I'm going to sleep, or else I was so sick I couldn't do nothing else. I'm going to sleep. We ain't even dealing with it. But I grew out of it. Know what vision impairment is. It's just not being able to see. Some people are actually born or they can't see, or it develops, or some kind of traumatic injury causes it. But we're going to learn about the cataracts. Underline, cataract may develop. What happens is the lens of the eye becomes cloudy. Put the lens becomes cloudy. And just underline those words. The cataract develops, the lens becomes cloudy. Underline that. Or they may have glaucoma. And a lot of times they can occur suddenly or with aging. It causes severe pain sometimes, nausea, vomiting. This is your eye. And it can mess you up. If you have too much pressure going on your eye, because it's going to affect that optic nerve, they can do some other things as well, and cause you to go blind. So if they tell you have glaucoma and they give you drops, it's kind of like blood pressure drops to your eye. You need to be taking them. I know a young fellow that will not take his stuff. He's going to be blind sooner than later. He's going to go blind, and hopefully no other things is going to mess with him. But you're messing with some real stuff when you're messing with pressure in your eyes. And make sure that they may have blurred vision, tunnel vision, blue-green halos around the lights. If you're looking at a light and you see blue and green halos, which just means it's circled. I see halos, but they're not those colors. And that's just something wrong with my eyes for real. But I see some everything. But just know that if somebody ever describes that, we need to go get their eyes checked. And they don't go blind. And we're going to end right there. So that is part 1. We're ending on page 87.